All right, everyone. Um, as everybody is slowly finishing connecting to the audio, just wanted to say welcome to everybody on this fine October afternoon slash evening, potentially morning, depending on where you're coming from. Um, and we're going to be getting started in just a moment. All right. Okay. Can everybody see my screen? Okay. Excellent. Put that down there. All right, everyone. So, if you're here, you probably know who we are, but we like to do the same intro kind of every single time just to get everything going. So, welcome again to another amazing lecture of Gaumi. We're Wilderness Medicine Education Lecture Series. If you are here, you probably have gone to one of our previous ones, but if this is your first time, welcome, and we hope that you come back for future ones as well. Um, a little bit about our mission statement. We're trying to create like an educational platform for students and healthcare professionals to try and interact with wilderness and emergency medicine as we go and craft an international community uh, of all of these professionals at the same time and really kind of connect everybody through mutual learning. This is our executive board, slide 1, and then slide 2. Um, and this is our fall speaker series for the future ones that we have coming up, as well as some of the other talks that we have had in the last few weeks. That November slot is full, so there will be a talk early in November. We just got to update this. And then, as always, follow us on Twitter and Instagram, or just go to our website and you can find a lot of our prior lectures and share recordings with friends if you think it's something that would benefit them and they'd really like to see. Also, join our mailing list. We have this nice little QR code if you want to just go and do that. Um, and we do these lectures bi-weekly, as you saw, typically trying to follow a school-based semester system. And the mailing list and the website are really awesome for putting up wilderness opportunities. I believe we have our fellowship showcase coming up as the next talk, if I'm remembering correctly. And we also advertise a lot of different conferences and stuff that are going on as well. So really awesome resource. Highly suggest signing up for it. Um, and yeah, and before introducing our speaker, I just want to kind of give the normal reminder that we like to see everybody's faces. We know, sometimes you might be sitting in bed. That's totally fine. You don't have to. But if you are able and willing to turn your camera on so we can see everybody where you're coming from, that would be awesome. And without further ado, we're going to introduce our speaker. So our speaker today is Dr. Nour Khatib. She's an emergency physician in Toronto, working community sites around Canada, and several times a year also works in remote northern communities in the Northwest Territories and Nunavut. She's currently the professional development education lead at Lakeridge Health and lead preceptor for Lakeridge Health Learners. She's a VP of finance for a not-for-profit emergency education organization, creating educational events for community emergency doctors. And prior to her career in medicine, she was a financial analyst for Pratt and Whitney Canada and has a background in finance with an MBA. Her unique work and life experience have fueled her passion for leadership, patient education, and quality improvement. And without further ado, I'm going to stop my share and let Dr. Khatib take it from there.
Hello, everyone. Good afternoon, good morning, good evening, wherever you're coming from. Let me share my screen. Thank you so much for that introduction. Let's go ahead and share. So feel free to follow me on Twitter at Nour Khatib MD. Would love to interact with you guys. If you have any questions about the talk, drop me a message, or if you have any questions about future talks, drop me a message. Would love to interact with you guys and keep in touch later as well. So my talk today is cases from the Great White North. So as Ian mentioned, sometimes a few times a year, about 3 times a year, I go to the Northwest Territories or Nunavut, basically certain territories in Canada where there's a lot of remote medicine there, not a lot of doctors, not a lot of nurses, but definitely lots of patients and not a lot of resources at all. Right now, I am working at Markham Stouffville Hospital. It's a community hospital in Toronto, the urban jungle that is Toronto. So when I do go up north, it's quite the breath of fresh air to just see something different, be in a different environment. And honestly, personally, it's helped me mitigate my burnout by just changing location and diversifying what I do. It's still emergency medicine. It's just, you'll see it's very, very different in such a resource limited setting. So cases or stories from the Great White North, I want you to sit back, relax. This is going to be a lot of storytelling, very informal. I believe we've got someone keeping track of questions. I'm happy to answer them after. And let's get right into it. Now, I am talking to you from Toronto, so I have to do a land acknowledgement. I acknowledge that the land I'm meeting you on is from the Sagas of the Credit, the Ashmanag and the Shishpua, the Haudenosaunee and the Winnemem people. It's now home to many diverse First Nations, Inuit, and Métis people. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. I would like to, hold on, sorry. Oh, it kind of froze because of the people that are coming in. Oh, there we go. I'd like to talk to you a little bit about what my objectives are today. So I just want you to appreciate the complexities of working in a remote setting or a low resource setting. I want you to realize that it's not only dealing with the patient in front of you, you're, as usual, as an emergency doctor, you're treating the emergency department itself as a patient, right? So you're thinking about flow, you're thinking about how the emerge itself is functioning, right? That's what we do in the emergency department. But at the same time, when you're working with remote medicine, you have a third factor. You're considering all the flights from all the remote regions and all the patients that are coming in from a large geographical territory. So you've got your patient in front of you, you've got the emergency department that's also a patient of yours, and then now you've got triaging of numerous expensive flights from remote communities. Okay, and these aren't flights that the like patients are paying for. This is all in Canada, so it's all covered. So it's taxpayer money, and you have to really be able to triage these flights appropriately. Then we'll be talking about telemedicine. So if you've ever heard of telemedicine, ACLS, ATLS, PALS, that's what we do up north. There's not enough doctors, but there's certain nursing stations, and you'll see very quickly that a lot of it is managing these terrible codes on the phone or through video conferencing. We're going to learn a little bit about infectious diseases of the north, and I'm hoping to pique your interest on working in remote areas. So a little bit of background. Why the heck would someone leave the comfort of their own home with all the resources in the world at your fingertips and decide to go somewhere where you are alone and very, very, very cold? And I mean cold to the bones. And you really are alone. You've got the nurses working with you. You've got sometimes a lab tech, but very often it's the nurse that acts as a lab tech, and you don't really have that much imaging. We'll talk about that as well. But why would you do that? So what happened with me is June 30th of my graduating year came, and it was very exciting. It was like, great, finally, no one questioning my decision making. I can finally, practice appropriately and not have every word or every case that I need to review with others and have people sign off on things. Like, this is wonderful. June 30th, I'm excited for July 1st, where I'm going to be a staff attending, and the world's my oyster. I'm finally going to be working as a staff physician. But you know what? July 1st came, and it wasn't as glorious as one would think. It's scary. It's lonely. It makes you feel like this picture feels very, very uncomfortable. So how do I deal with this discomfort of making decisions and being scared starting July 1st of being an emergency doctor? I did it the old-fashioned flooding way. So I decided I will flood myself in environments that I am completely uncomfortable in, and learn as I go and be as comfortable as possible with the unknown. Because as emergency doctors, this is what we do. We, as emergency doctors, we are dealt with the unknown every single day. But if you add the unknown plus the low resource setting where you have very little in your fingertips, then it's truly it's truly flooding. It's true, but it's quite humbling too. And sometimes I think to myself, you know what? It's actually less scary because you have to do whatever you can with the limited resources you have. You are the standard of care when you're up there and you're by yourself and you're just trying to do the best you can do. Your clinical acumen goes up for sure because you're no longer, at your fingertips ordering a CT or an ultrasound or calling a specialist. You have to really go back to your basics that you learned in medical school and try to treat the patient in front of you as best as you can, as you are the standard of care when you're up there. And when I say you're up there, what do I mean? I mean far. I mean northern Canada, very, very remote areas. These are a few of the areas that I've worked in. The highest place I've been to was actually in, let's see if I can do that. I don't know if, yeah, the highest place I've been to was Cambridge Bay, somewhere over here. But Inuvik is the northernest place that I've worked in, and definitely one of the more remote places. Iqaluit is the capital of Nunavut, so still a little bit more resources. Fort Smith is a tiny town, and although it's in the border of a big province that has lots of money, it still has very, very limited resources. So these are the different places that I have worked at, and I'll give you some stories from each. So where am I looking? So basically there's the Arctic Circle, and I've worked in Inuvik, which is right above the Arctic Circle. And then there is something called the tree line. So if you look at the dotted line here, the tree line is an interesting line geographically. Does anyone know what a tree line is? Just curious. Yeah, I see some nods. Okay, great. Because you know what? I didn't really. I didn't when I first started going up there. I was like, what do you mean a tree line? Like a line of trees? No, this is where above the tree line, no more trees grow. That's it. It's over. No trees for you, right? And it's a bit weird. I never thought I would miss a tree. I know that after a long few weeks of working up north, and I landed in Yellowknife, where the star here on the kind of top left. When I landed in Yellowknife, I felt like I wanted to hug a tree after. I was like, never thought I would miss one. But basically, I'm originally from Montreal. I work in Toronto. Ended up going all the way to Cambridge Bay, pretty far. That's me pretending to surf a block of ice. And our stories begin in Nunavut. So this is the flag of Nunavut. There's about 10,000 people in Iqaluit, which is the capital. And I have to tell you, they are obsessed with Amazon there. I know everyone thinks that you're obsessed with Amazon. Trust me, if anyone's, they're obsessed with Amazon there. Why? You can't really get anything there. There's no railroads. There's no roads. It's a town, I'm going to call it, not a city, even though it's the capital. It's a town where the only way to get in and out is through airplane, or if the water is not frozen, then through ship. So the only way to really get things is through that, and it's extremely expensive. What happened is when Amazon came to Canada, it promised to deliver to every capital city, no matter what. And guess what? Iqaluit is a capital city, so they're benefiting from the fact that Amazon made this promise. So so everybody gets everything from there. So that's their like kind of a link to the rest of the world. That's just a side bit about Iqaluit. This is the view from the apartment I was staying at. This is a church here that it looks a little bit like an igloo. Very beautiful. I believe this was at 2 in the morning. So keep in mind, in the summers, there's 24 hours of daylight, and in the winters, there's 24 hours of nighttime, which really messes with your biological clock. When you're walking home at 2 a.m. from a shift and it's super bright outside and you're ready to go to bed, but your body says, hey, no, get out and do something outdoorsy. So this is the path that I had to take from this apartment building to head to work. As you see, there's no tree in sight. It looks like just nice big boulders and rocks, and it's quite amazing. You really feel like you're on a different planet when you don't see trees. You don't realize it until you get there and you look around and you're like, where are all the trees? Where are the shrubs? And there's really nothing around. I put a picture of a tomato because I was shocked when I bought this thing. It was $5. I mean, nowadays with inflation, our tomatoes here are coming close to $5, but back then, a few years ago, this little tomato that I bought was $5, and we ask ourselves why the First Nations and Indigenous people are might be eating unhealthy. Is just there's no food that is available for for appropriate prices. It's just some beautiful pictures of the ice melting. So let's see. In terms of low resource setting, what did I have when I was working in these regions? Number of CT scans. In Fort Smith, I had nothing. In Moose Factory, I had no CT scan. In Iqaluit, I had one CT scan for this entire region of Nunavut to take care of this entire population. And in Inuvik, I had 0 CT scans. So I had the luxury of a CT scanner in Iqaluit, and that's it. Ultrasounds, maybe an ultrasound tech might show up once every 2 months. So so if you're working in the family medicine clinic there, then you'd refer, you'd send a request for an ultrasound and maybe get it in 2, 3, 4 months, depending on the waiting list for sure. So CT scanners, if a CT scanner comes and there's funding for it, it makes the news. So that was the CT scanner in Iqaluit. When it first came on, oh my God, it was a big deal. It was definitely a big deal. Now, lab services. How can I actually check a troponin, guys? Like, I'm an emergency doctor. Someone comes in with chest pain. How am I going to get that trope? Right? So let's talk about lab services. No lab services in Fort Smith. No lab services in the Moose Factory. None in Iqaluit after 5. But from 8 to 5, usually you do have. You're allowed to call them in if there's an emergency in the evening or overnight, like a true emergency where you absolutely need the blood work right now and it's going to change your management right now. Then you call them in. And this isn't, I need this blood test maybe. No, this is, you have to be sure of it. These people are working. They're probably the only ones on for weeks and weeks and weeks on at length. So imagine being the only one working and you keep getting called in every night. So you have to be very careful when you call anyone in, like lab techs to draw blood or to get you anything. So in Inuvik, again, I had the luxury of a lab tech from 8 a.m. to 5 p.m. So what do I do if I get someone come in with chest pain at 9 p.m. in Fort Smith, let's say? We've got these little machines called iStat machines, and they're able to give me a trope, a chem 8, and a pH. That's about it, okay? It's pretty good for what I need to answer for certain emergencies, but that's it. That's all I get, a trope, a chem 8, or a pH, okay? If I absolutely need blood work immediately, then sure, I can fly the blood work out, but then who knows how long it will come back. Good luck with that. It's gonna be a while. So in terms of surgeons, surgical emergencies do happen in these areas. They'll happen anywhere. I had no surgeons in Fort Smith, 1 surgeon in Moose Factory, 1 in Iqaluit, and 1 in Inuvik. So really in Fort Smith, that's where it's kind of scary. You don't have a surgeon there. Your nearest surgeon is about 2 hours by flight. But we've got general surgeons. Now, I don't know if you guys have this in the US, but sorry, general surgeons in general, but like, of course you have general surgeons, but I don't know if you have this in the US where family doctors can do extra year of training and train as surgeons. This only happens and is done in remote regions where they're absolutely very, very desperate. For example, in Inuvik, my colleague did his family medicine residency and then did an extra year of training for simple, I say simple, but in reality, every surgery can be very complex, right? You never know, but simple procedures surgeries such as lap choles, lap appies. But I know that he has had to do ectopic pregnancies, C-sections, all sorts of things. So even though he's trained in family medicine, he's on an extra year of general surgery. But that's just one extra year. How much could you possibly know, right? But in a region like that, you're kind of stuck. Your nearest general surgeon, if I'm in Inuvik, my nearest general surgeon is like 3 or 4 hours away if flights go well, right? Because very often you're triaging between different flights for different patients. So you're stuck with someone who can do the lap chole or the lap appy versus a general surgeon that's very, very far away. Some things that the general surgeons, for example, in Iqaluit, there's a general surgeon that has had the 5 years of residency and has not done family medicine. They do all sorts of surgeries. Your common general surgery procedures, they do C-sections, orchiectomies, vasectomies, they do all sorts of things that normally, if they were in the city, they would not be touching because there's the specialist of, the fifth toe that deals with that, and you're not allowed to touch it, right? Side story in Iqaluit, this very, very sad story, actually. There was 2 cousins playing and they found a hunting rifle, and they didn't realize it was loaded. So unfortunately, like one was 12, one was 11 years old, one was 12 years old, and the 11-year-old kind of pointed it at his cousin, and unfortunately it was loaded. So the 12-year-old got shot, and the general surgeon there, they tried everything, and then in the end he decided to do a thoracotomy in the middle of nowhere. Right, in Iqaluit, in the middle of nowhere. There's no vascular surgeon or specialist or tertiary center in sight. In fact, the closest one is, I don't know, 6 hours away or something of that sort. They had to call in a very special aircraft to come and take the kid all the way to Ottawa to the ICU there after the thoracotomy. And luckily, 3 to 4 weeks later, he actually was able to walk out of the ICU. Which is just an absolute miracle. But this general surgeon at that time had to make a decision between this is futile and this kid's going to die versus I will at least try thoracotomy. And although it's extremely risky and nothing, and we might not be able to save this kid, but it's between not being able to save to this kid and maybe a less than 1% chance. And the whole everything worked out, but it was very, very scary and very unusual. But when you're in a resource limited setting and you've got the patient in front of you, you're just going to do what you can to try your best to save them in the best way that you can. Nobody would have faulted him had he not done thoracotomy. It definitely is not something that is usually done in such a remote area. Number of RTs, respiratory therapists, very important for me here in Toronto. Respiratory therapists save my butt all the time. No respiratory therapists, except I had one in Iqaluit. Between January and April, that one respiratory therapist was on call 24/7. So I had one, but I had a very, very tired one, and one that I should not be calling unless absolutely necessary. Okay, so just keep that in mind. Very, very resource limited. OB, midwife, because trust me, you don't want me delivering any babies. There are general practitioners who are trained in OB, and so they would do the deliveries. And then in Fort Smith, there were midwives that not only did the deliveries, but did the ultrasounds and did all sorts of things that they were trained for. So this is the region in Nunavut where this entire region that's circled had just one CT scanner that was in Iqaluit. So you needed to fly all the way there to get the CT scanner. If someone needed to go to the ICU, they were flown from these areas all the way to either Ottawa, Winnipeg, or Edmonton. And that's only if absolutely necessary. All right, so onwards are the stories. So I am in Iqaluit now, so I'm in Nunavut. And if you remember from our resource perspective, it was actually the town that I had the most resources in, really. The thing is, I'm also the capital in that town. And so I'm servicing a large number of people in a large geographical area. There's something called a community pager. What a community pager is one doctor is responsible for this pager, and nurses from nursing stations all throughout these areas, all throughout the circled areas, will call me if they have any questions about patients that come to their nursing station. These could be questions as small as lacerations, to overdoses, to all sorts of things. So between 10 a.m. and 6 p.m., there's the community pager, nursing stations are calling. There's about 20 to 30 calls a shift. So try seeing patients and also getting these calls and trying to manage them. And they can vary from lacerations to code pinks. Just a sample of some of the cases you get on this community pager, which was the bane of my existence, this pager. But they're important calls. Like, who's going to service these patients? There's nurses who are working remotely in areas that are much further than you are, and they have way less resources than you do, and they just need your advice over the phone as to what to do with this patient, or whether this patient needs to fly to you for an examination. So, for example, someone who's a Tylenol overdose, and the nurse will immediately start NAC without even talking to you and send the blood work on the plane with the patient to Schedule 1 facility. So they'll start the NAC and call you right after and then discuss the case. So this is the beauty of the nurses up north, is that they're just on the ball like that, and they're used to not having any resources. Diverticulitis, renal colic, no imaging unless absolutely like an acute abdomen that you think is a surgical abdomen. Because don't forget, a $10,000 to $20,000 flight for emergent imaging. So you'll just treat the problem, hope that it gets better, and reassess the patient in 48 hours or so. Just ask them to come back. We did a lot of that. Here, I'm going to treat you for this. We don't have a CT scanner, but I'm going to treat you for this, and I'll see you in 48 hours. Come back to the emerge at this time I'm working, and I'll reassess you to make sure that things are going well. All right, so for an appy, and you don't have an ultrasound tech and you don't have a CT scanner, your hand is the ultrasound, or they do have ultrasound machines in all of these places. No ultrasound techs, ultrasound machines. So your point of care ultrasound or bedside point of care ultrasound needs to be really good. But again, as emergency physicians, we're limited as to what we know how to do and what we're taught and really what's under our scope. Lots of people just kind of teach themselves through YouTube and all of that, and that's wonderful. I remember a case where I had a 17-year-old coming in with right lower quadrant pain, and I was pretty sure it's an appy. Like, it felt like one, it looked like one, he was behaving like one. I was in Fort Smith, so there was no blood work, there was no imaging, and there was no ultrasound tech at the time, although I could have been lucky and there could have been an ultrasound tech. But there was none of that. So I don't know how to ultrasound an appy. I'm not trained in that. It's not actually part of our what's it called, like curriculum whatsoever. But I decided to just put my ultrasound, I put my ultrasound probe on the patient and dug around a bit, and bam, this image popped up. And I was like, oh, looks like a blind-ended tube that is around the area where an appendix might be. So I took a picture, sent that picture to the surgeon. The surgeon said yes immediately. We sent him off on the plane and he got his appendix removed. So, I mean, the alternative is he goes with no imaging, which is fine. It's just you might be doing overcalling it, or it might be something else, or it might be just constipation, or who knows, right? But especially without any blood work and without any imaging, the ultrasound skills or ultrasound comfort was helpful at that time. I did watch a YouTube video before doing it, but in all honesty, that doesn't really help as much. I did need to like practice and dig around to get that beautiful image there. All right, next, if you have a surgical diagnosis and you're in Iqaluit where there's a general surgeon there, great. You made the surgical diagnosis, you call the general surgeon, you're the surgical assist now. In Fort Smith, where there's absolutely no specialist and absolutely no one but really just you in the hospital, there was once a compartment syndrome where my colleagues had to do a fasciotomy guided by orthopedic surgeons on the phone. And that was simply because they had no time to send this person to the big city. If you're in Fort Smith and you get an admission, guess what? You're now the hospitalist. Yes, you trained as an emergency doctor. You've always worked as an emergency doctor. But when you're up there, you're all of it. You're their family doctor, you're their hospitalist, and their emergency doctor. So some things to keep in mind when you go up there, and that's why it's kind of scary, but at the same time you learn a lot, and you just learn to be as resourceful as you can. And you need to realize that yes, you're in the middle of nowhere. Yes, you don't have anything physically around you in terms of resources, but everyone is a phone call away or a video call away. You're not actually alone. I've had very long discussions with cardiologists over the phone for management of certain patients, and you know, they understand that you are in the middle of nowhere. They understand that, and they'll try to help you as best as possible. So yes, you're alone physically, but in reality, everyone is a phone call away. All right, imminent airway loss. You're going to intubate and bag mask ventilate, but you don't have any ventilators, so you're just going to bag mask. You're going to intubate and ventilate manually. And if you don't have an RT, then you can Skype with an RT, yeah, as needed. I just have a quick side story that I'll get to in a second. But with sepsis, it's easy. You're going to start the antibiotics anyway because it's a clinical diagnosis at first. Your blood work will show up in forever because it's going to go on a plane and then come back in a couple of days. And cultures will take, I don't know, I remember cultures took like 10 to 12 days sometimes. So you're really going to have to focus on your clinical acumen and try to get that as strong as possible. And you will be scared at the beginning, but you're just going to realize like this is the best you can do with what you have. You're going to feel humbled by that. It's going to be painful at first, but honestly, I look forward to all these trips every single time. There's always a little bit of anxiety right before, but when you're there and you're there with that one patient, you're taking it one patient at a time, you just do the best you can. In terms of if someone, let's say, is suicidal with plan and needs to be admitted to a psychiatric facility, and you need to what we call it in Ontario, form them, so keep them involuntary basically. You keep them involuntarily, but involuntary basis, but the visit with the psychiatrist is done virtually. So that's kind of how they've mitigated all the long trips in up north. So a lot of it is now virtual visits. Now with COVID, things are getting more and more virtual, but this was well before COVID. And I love how like in the middle of COVID, everyone like virtual medicine or virtual telemedicine has become such a big thing. And then up north, we've been using it ever since the invention of the telephone, right? It's not been new whatsoever. When you're absolutely desperate for something, you will find a way. And with the phone or video call or video chat, you'll make it happen. So telemedicine has been long available up north, that's for sure. So my side story, what did I want to tell you? So I don't know if you guys listen to EM Cases. This is how Ian had found me, because I contribute to EM Cases sometimes. It's a podcast done by Anton Hellman here in Toronto. It's a wonderful podcast. I actually talked about this story in the latest issue of EM Cases. But I was in Wyerton, which is a tiny little beautiful rural town in Ontario. And it's about half an hour from a beach. And it's a lake, but there's a beach. And even though it's a lake, our tides here are humongous. It really does feel like an ocean, even though it's a lake. So sometimes people don't know this and they're coming in just visiting from out of town, and they go swimming and they don't realize how big the tides are. So unfortunately, we got a patch in saying we've got a 23-year-old and 24-year-old that have that basically that had drowned but non-fatal. GCS of the 23-year-old female was between 10 to 8, and what happened is when they came in, very quickly we recognized that the 24-year-old male was absolutely fine. He was talking. He was more worried about his girlfriend than anything. And then the 23-year-old female was, GCS about 10, respirative about 40 to 50, not doing well. She was intubated. We did have a ventilator, so we put her on the ventilator. And so after I intubated her, by the time the vent is getting set up, I'm manually ventilating her, right? She's intubated, but I'm manually ventilating her, and everything's going well. Her oxygen saturations are 100%, everything's good. As soon as I hook up the ventilator, the oxygen levels drop down to like 89, 90, and I'm just finding it very odd. Like, why is the ventilator not doing a good of a job as that I'm doing? Like, it doesn't make any sense. We check our settings. Our settings are wonderful on the vent. It's exactly the settings they should be. And then again, I remove the vent and I use my bag, and she goes up to 100%. and I don't have an RT there. If I was in Toronto, this problem would have been solved within seconds without even my knowledge. RT would have done what was necessary without even letting me know. But at this point, we're kind of like stuck, and we're just, so I ended up manually ventilating her. And we called, our nearest ICU was about an hour away. So we called them, giving them a heads up that this patient's coming. So courtesy call for sure, that, hey, this patient's coming your way. And I very frantically said, can you put RT on the phone? I had RT through video chat take a look at my vent settings, and the RT's like, yeah, this is exactly the vent settings you need. And then just look at all of the connections. And RT quickly recognized that, let me see, it shows up here. Yeah, this is a picture of it. This is a picture of the exact one. That's great. Okay, so RT quickly recognized that I had two filters on. I had this filter right here. Let's see. I had this filter right here, then I had this filter right here. So the peak pressures were quite high, and so it wasn't delivering what it was supposed to deliver given the two filters that I had. So RT quickly told me, like, Nour, you just need to remove one of them, remove the one that's right here. That's why when I was manually bagging, everything was fine, because the first filter was in there, the one right here. So anyway, again, something that when I would be in the luxury of an urban center, it wouldn't even cross my mind, because RT would have fixed it without my knowledge, wouldn't even have mentioned it, right? So anyway, just something that made me feel so humbled to when I go back home and I have all the support, just small things like this that you wouldn't know. All right, next, what happened? So next, I'm in the ambulance, and me and the nurse are taking this patient to the nearest ICU, which is about an hour away. And with all this kerfuffle, this whole thing took longer than an hour. And in the ambulance, the patient's rest rate goes up to 32, and we're like, what's going on? Our vent is not at 32. Our vent is at, I think it was like we had put it at 16. So is just, again, something that RT probably would have recognized. But then right away I was like, well, we've been doing this for so long. The rocuronium used to paralyze the patient was basically gone, so we ended up just paralyzing the patient again in the ambulance, and all was well. And the patient made it to the ICU, and unfortunately she had a very long stay in the ICU. Her submersion was about 20 minutes, according to her boyfriend. So I don't know what happened after that, but I know that she was alive about a week later, still intubated. But it was quite the case for her and for them as a family, for sure. All right, appropriate triaging of numerous expensive flights. If you remember, the community pager comes in, and the nurses up north, they're able to do so much. So there's certain nursing stations very far away that that are like, I don't know, 500 kilometers away from me. They can do x-rays, they can do basic x-rays. There's no x-ray tech, but they just literally just take a random picture. No protocols or anything, just a random picture. So you can teach the nurse on the phone or through video call how to reduce a dislocation. I remember once there was a fish hook, and I'm not gonna get taxpayer money, spend $20,000 flight for a fish hook to come all the way to Iqaluit for me to remove it, for the patient to go all the way back. So I taught the nurse over the phone and through video, through this MRAP episode, how to remove fish hook. Oh, it was so satisfying for the nurse. She absolutely loved it. The nurses in Nunavut are so incredible, because they are able to deal with all these crazy overdoses that happen. And of course, they need our support over the phone, and they need patient transfer, but they deal with that life-threatening first 10 minutes, right? Until they can reach one of us. For example, this is one of the remote communities where there's a nursing station. There's only 198 people who live in this community. It's called Resolute is the community. Very, very far. And the nearest doctor is in Iqaluit. So that's where I was, and I was getting calls from Resolute. And this is pretty much how expensive the flights are. So Yellowknife is still a small center. It's the capital of Northwest Territories, but it's still not that large of a center. And then if you need like ICU care or something much more serious, you need to go to Edmonton. So that's basically a $50,000 flight or so. There's two ways to send people out. There's something called medevac flights, and there's another thing called skedevac flights. Medevac flights are quote unquote immediate, meaning you need the flight right tonight. And Skedevac, as it sounds, it's scheduled. So in fact, I had to send a patient on a scheduled flight to for a broken jaw to see a plastic surgeon in Edmonton, and I was on the flight with the patient. I was heading home, but they were on a scheduled flight, so it was a regular commercial flight. They were just scheduled, and they happened to be sitting next to me, so it was a little bit awkward just being there with a patient that you just saw yesterday for their injury, and you're sending them on the same flight as you. All right, so here is an overnight flight that I had, overnight shift that I had in Iqaluit. This is me, very excited, one of my last shifts in Iqaluit, and I walk in, and then there's this big white board where the doctors throughout the day, they write out all of the medevacs, so all of the very serious emergency conditions that are heading my way tonight. So I've got 3, which is relatively busy. There's 3 coming in from Igloolik, Parangatang, Kalpang, and Clyde River. And these are the times that they're able to come. And these are generally what the issues are. So an 11-year-old with torsion, but it's been at least 4 hours. By the time he actually comes, it might be too late. And then a 19-year-old vag bleed with a positive urine beta. We don't actually know if it's an ectopic. And the nurses there, they don't have ultrasound, or they don't know how to use POCUS. So we don't actually know if it's a ruptured ectopic. And then we've got in Clyde River an overdose or a decreased LOC, and we don't really know what it is. It could be someone who's just, ETOH intoxication, or an overdose that's intentional overdose, and we need to take care of it. All these things are like, I can have all the priority I want, right? Like I can say like, hey, I want to see the overdose first. I want to see the 19-year-old female vag bleed second, and then the torsion who, it's already been 6 hours, let's say, last, or whatnot. I can put any order I want, but it's all going to depend on the weather, the pilot schedule, and the many other requests coming from other areas. Okay, so I can, put my priorities, and if it's very, very serious, then I can kind of override things. But there's lots of things that come into play, including pilot schedules. The pilots cannot have worked in like 12 hours before the flight they're about to take. So it's very finicky. It's not as straightforward. All right, so I walk into this board, right? And then literally like half an hour after, I get a call from the red phone. And we know that when we get a call from the red phone, that means it's a code happening in a community site very, very far away that only has a nurse. So this is a telemedicine resuscitation. Remember I told you we're going to do telemedicine on the phone? We're going to do ACLS on the phone. This is a 12-year-old from the Arctic Bay who was just fishing with his family. He's known for epilepsy. And unfortunately, he began to have a seizure in the middle of the lake, fell off, went into the frozen lake, had a generalized seizure for about 5 minutes. Grandfather jumped in, rescued him, brought him to the nursing station. And those are his vitals right there. Heart rate of 130, temp of 31, blood pressure is fine, respirates 22, and glucose of 5.4. His GCS is about 11. So now I add someone to my board, and I need this kid to come as soon as possible. Now, of course, the nurses there already have started the warming protocols, already have started having oxygen on the patient. They don't have any BiPAP or anything, but the max they can do is increase the oxygen rate as much as possible. But now I've got 4 of them, and I've got all these issues with weather. And that night, even though it was in the middle of summer, the weather for whatever reason was awful because of fog. Later, I hear that our gentleman here in Clyde River, number 3, actually admitted to antifreeze. So admitted that it was antifreeze that he took about 12 hours ago. And 12 hours ago, antifreeze, you're going on like a higher stage. So his GCS is like now 13, was about 15 earlier. Just a little bit of a quick overview on ethylene glycol found in antifreeze, aircraft de-icing, ingested as a suicide attempt or as an alcohol substitute. So ethylene glycol itself is not toxic, but it's metabolized by ADH and ALDH to toxic metabolites such as oxalic acid and glycolate. So those are the ones that are toxic themselves, okay? It causes renal toxicity, causes anion gap metabolic acidosis for the glycolate. There's multiple stages to ethylene glycol poisoning, right? At the beginning, it's just a little bit of, as if you're intoxicated with alcohol. And then stage 2 is where this person was at. So this is the worrisome part, is that he's about to become hypotensive, tachycardic, and maybe even go into pulmonary edema and ARDS. Stage 3 is where he's heading. And I was very worried about this patient, because let's say he does come to me in a calorie. How many resources do I really have to help this guy? Right? Like, what am I going to do? I'm going to intubate him, take care of him, supportive care. He needs a tertiary center ICU. He really he needs to bypass me completely, in all honesty, especially with the busy night I'm about to have with the others. But this is the card we're dealt, and we have to continue and just try to help as much as possible. So in terms of diagnosis, the gold standard is ethylene glycol levels. Obviously, I don't have that. I don't even have that in the large community sites I have here in Toronto. They come back, I believe, in a few days. You suspect this if the osmolar gap is high, the anion gap is showing metabolic acidosis, or if there's acute renal failure. You can see oxalate crystals in the urine. Some brands actually have fluorescent dyes to help you be able to see in UV light, so you can identify it in the urine in UV light. The antidote is fomepizole or ethanol. Okay, why? Because you want to block ADH from preventing the toxic metabolites. You don't care if there's ethylene glycol there. You don't want the ethylene glycol to convert to the toxic metabolites, right? The response to treatment, serial bicarb levels will help you understand if you're going in the right direction. You also add thiamine and pyridoxine to help convert the glycoxylic acid to non-toxic metabolites, okay? In reality, though, this is a very, very serious life-threatening event. The person will need hemodialysis. Remember I talked to you about those machines I have, those iStat machines? So that community did have an iStat machine. I was able to see the pH. I was able to tell that his pH was low. And so in fact, for this guy, so now he's added to my list, and I have it's number 3 is actually pretty serious, not the alcohol intoxication that it could have been. It's actually quite serious. In the meantime, I call Arctic Bay. The kid is fine, and in fact his temperature is rising, so that's good. In Pang, the patient is actually sleeping comfortably, her pain is controlled, and her vitals are normal, so I'm not too worried. In number 1, Igloolik, the 11-year-old male who's waiting for his flight, unfortunately does not feel pain in his testicle anymore, which is usually a sign that he pretty much has lost vasculature to the testicle, and it's been quite a while. He admits to feeling it about 7-8 hours ago from that time that I called in and checked on all these people, but it could have been before that, because he did have a little bit of pain 2 days before that when he was playing soccer and got punched in the area. So now I have a bit of an idea of priorities, of number 3 being my main priority right now. Number 4, the nurses were doing a great job, so that's fine. So my main priority is number 3. I called and tried to get number 3, the gentleman in Clyde River, to me as soon as possible. There was one plane all the way in Winnipeg, and this is 2 provinces away from me, right? That could fly all the way to Clyde River and take this patient. But I felt like that still wouldn't be the right thing to do. This patient needs to go to an ICU. I called up the Ottawa ICU. It happened to be my preceptor from back in the day when I was a resident. And I reminded him of myself when it's good to know people, honestly. I told him about the case, and he's like, no problem. We accept the case. Patient went, bypassed me completely. I managed it over the phone with the nurses. The nurses had already actually started the antidote of fomepizole. They had fomepizole, and they started the fomepizole. All they had was thiamine, but they didn't have the pyridoxine. That's fine. You do what you can. So they started the fomepizole. They started the thiamine, and we tried to get this massive plane ASAP to go get this gentleman in Clyde River straight to Ottawa. To my knowledge, he got hemodialysis pretty much when he arrived, because his pH was about 7.1. And to my knowledge, he actually did well, according to the ICU staff that I spoke to. All right, I will skip the bonus case just because of time, and I want to make sure that you guys have time to ask questions. All right, give me just 1 second here. Just gonna turn on the lights a little dark here. I don't want to also feel like I'm in the Arctic, right? All right, so let's go back. Here we are, perfect. So let's learn about some special infectious diseases of the north. Just a couple of cases for you guys that I thought were very interesting when I was up there. Nothing that I would see in the city. So I've got a 44-year-old male, pretty healthy, no medical conditions, no allergies. Triage note just says laceration to the right V2 by knife while opening an Amazon box, of course, 7 days ago. This was in Iqaluit, of course. You know, just like a tiny little cut. It's literally nothing, right? And you look at the vital signs, and that's about it. Like, what are you going to ask? You're going to ask, you know, when did it happen? What kind of knife we're using? Is your tetanus up to date? These kind of regular questions. Anything pop out right now at you? I'm sure you guys are looking and you're saying, like, why is his heart rate 115? It's a laceration that he had 1 week ago. It's not like he just had it and he's, like, you know, in pain. I don't have a good explanation because everyone I saw in Iqaluit had a heart rate between 110 and 120. It was a phenomenal, like, I don't know. It's a phenomenon that nobody understands it. I spoke to the staff working there, and they actually like to they like to withhold that information from new people who come to the area, and they just want to see they want to see how you'd react, because like literally everyone has a heart rate of 110 to 120 at rest, just sitting there, not in pain. It's very odd. And I don't know if it's genetic composition or, you know, people of Inuit backgrounds having that heart rate, but literally if a patient is Inuit from that area, their heart rate will be between 110 and 120, even if they're an 18-year-old healthy male. And I tried to look it up. I tried to do like a deep dive on it. There was no information. It was just something that doctors up there know happens, and just ignore that number as long as the patient otherwise looks stable. So we will ignore that number for now. And I unfortunately have no real explanation for you as to why that happens. And we'll focus now on this very tiny laceration that really means nothing. Come on, you're an emergency doctor. It's a tiny laceration. You can do this with your eyes closed. You'd probably even glue it, right? So one thing you need to be careful of up north is something called seal finger, not the singer seal, but actually a phenomenon up north that's called seal finger. So when does this happen? Seal finger happens when either a seal bites you, or you are using a knife that at some point was used to cut seal meat. So it happens very often to hunters and seal handlers. Middle and index finger, apparently, probably from the cutting. Painful, swollen, red. They sometimes call it blubber finger or speck finger. And it's because of the marine mycoplasma that's in the mouths and waist of the seals and other marine animals. The incubation is 1 to 3 weeks. So, you know, you could cut yourself with a knife 3 weeks ago and then get infected later, right? The mycoplasma has no cell wall, does not respond to beta-lactam antibiotics. You really need a 4-week course of tetracycline. So your main question, and I know that, you know, we talked about like, what are the questions you would ask? And, you know, you'd ask all your regular questions, but your main question when you're up there is, has this knife ever been used for seal meat? And if the answer is yes, you're going to give this patient 4 weeks of tetracycline. You're going to give them 4 weeks of doxy or something like that, right? You're not going to ignore that, because if you do, here's what happened when a doctor who was new to the area came to see the patient, and this doctor saw the finger looking like this and said, "Oh, you've got an infection from a cut the cut that you had last week from your knife from opening that Amazon box, and you need to be more careful." And they updated the tetanus. They probably, this would just be glued, or, you know, just regular supportive care, cleaning, whatnot, but and they started them on Keflex. So painful right index finger, swollen, red, no trauma, started on Keflex for 7 days. But within 2 days of the Keflex, the redness started to get worse and started to move upwards, and the patient's finger was barely moving. It was just an awful sight. So the same doc saw them 2 days later and went, "Oh my gosh, this is a terrible infection. We need to start you on IV NSAID." No one told this doc about seal finger. So the patient was started on IV NSAID and things got worse. Finally, the patient was seen again and was identified that, we identified that the patient had used a knife that was once upon a time being used for seal, like a seal meat cutting, and it turned out to be seal finger. So the patient was started on doxycycline, and within 3 days, things magically got better. It was quite dramatic. So just ID in the north is different, very different from where I work. When you have diarrhea, you have to think Giardia. You start them on metronidazole. Why? Because of eating raw caribou, drinking from the land. If there's epigastric pain, oh my gosh. I think in the red general population, like, I don't know, 50% have H. pylori. Not many of the H. pylori actually does anything to you. But in up north, it's like over 80 or 90%. It's incredible how H. pylori is so rampant. So you start them on quadruple therapy. But you actually test for H. pylori in the emerge. We don't have that in Toronto, where we test for H. pylori in the emerge. I don't know if your sites do, but in the emerge there, it's so rampant that we actually do the testing in the emerge. So the H. pylori would be positive, you'd start them on quadruple therapy. So I know I'm cognizant of the time, and I did wanted to make sure that we answer any questions. This is the end of my talk, but I am not done piquing your interest in working up north, because I did want to show you a few pictures about working up north. And in all honesty, you guys, like, we've just been through hell and back with this pandemic, and it continues. I'm sure that your mental health and your burnout is reaching its peak. For me personally, the way to mitigate it for myself is to diversify where I work, so diversify the location and diversify what I do. And if you can take anything from the talk about working up north, just realize that working in other areas not only enriches you with your clinical acumen, but also helps your mental state, just to change location, to learn from other people, to meet new people and see new things that you'll never have seen otherwise and experience otherwise. You'll, see sunsets at 4 a.m. You'll see northern lights that are just absolutely gorgeous. This photo was captured on my phone. You'll just see incredible experiences in areas that you never would have gone, or you never would have experienced had you stayed in your rat race of working emerge shifts, or working what you expect from yourself to only do. Keep in mind that really these experiences really do enrich you personally and academically, and clinically. This is just a picture of when I went up north. This is the Toronto Pearson International Airport. Was completely empty in April 2020, when I went to help them with some COVID preparations. The airport was just absolutely empty. It was quite the sight. It felt like a ghost town, and it was, the busiest city in Toronto, and yet the airport was super empty. There was just 3 flights that day. Usually this board is like 3, 4, 5 pages long, and it keeps flipping. So just keep in mind that there's a lot out there. I love that you've got this group going, because it piques your interest in different parts of medicine that we're not usually taught in the classroom. So thank you again for your attention. I'm happy to take any questions. Feel free to follow me on Twitter or reach out if you do have any questions. It's at Nour Khatib MD, and I'd be happy to answer any of your questions. I'll stop sharing now.
Thank you, Dr.
Perfect. Thank you.
I do believe there's a couple of questions that have been dropped. So we'll go back to the first one. Somebody asked, would you go out of the hospital for medevac in smaller villages or even on bush calls as a physician?
Would you go out of the hospital on medevac? If someone is unstable, then yes, I would probably call the on-call doctor to either go on my behalf or take over the emerge as I go. But just keep in mind that a lot of times it's very uh, they're very short on doctors, as we all are right now. So as much as possible, you try not to send a physician. You might send a nurse, although you're even short on nurses. But if you remember my story from the drowning cases, even though it was an hour away, the ICU, and the patient was, intubated and everything's fine, I still went with that case, and the on-call doctor was able to take over the emerge for the time that I was gone.
Awesome. Uh, Somebody was wondering if you ever work with or collaborate with registered dietitians.
In the hospital for inpatient, there's registered dietitians, but as an emergency doctor, there's really not much collaboration until I admit someone to hospital and I'm the hospitalist. Then I am interacting with registered dietitians. Yeah.
Gotcha. Makes sense.
And there's definitely, if you're a registered dietitian looking for work, oh my gosh, trust me, up north or in Northwest Territories or Nunavut or anywhere remote, they need you. They need healthcare professionals, no matter where you're looking, no matter where you're going. So you will be needed. You'll be needed in more of the hospitalist setting for inpatients, but you'll definitely be needed.
Speaking of need, somebody actually asked, how long are the deployments to these remote locations, and do they accept American licensing?
Um, I think so how long? So how long? Usually minimum 2 weeks. They prefer three. And as long as you want, because they're always desperate. And in terms of American licensure, you might be able to actually, because what you have to do is you have to you have to get as an American, you can work in Canada with your license. The reason I know this is my colleague is an American who moved here, and she didn't really have to do any extra exams. So once you have your license here, then like me as someone from the province of Ontario, I had to apply for a license in Northwest Territories because we have licenses in different provinces and territories. So yeah, I can't see why not. I'm sure it's possible. But I'm loving that I'm piquing your interest in NWT and Nunavut, but I'm sure that also in the States there's lots of beautiful remote areas that also need you. But please feel free to reach out. I'm gonna pop my email actually in the chat, um, in case you have any questions or need me to connect you with anyone.
Absolutely. And I think you had kind of alluded to this during your talk, but as an emerge doc in the, those northern Arctic areas, do you do a lot of primary care type responsibilities as well?
Yeah, so in Canada, you can do emergency medicine two ways. You can do 5 years of emergency medicine, or you can do family medicine and then a year of emergency medicine. I'm a little biased, but I'm lucky that I did the 2 years of family medicine and the year of emergency medicine, because in fact my services are much more needed this way, and I have broad, like broad clinical like knowledge that is kind of coveted in those areas. They want you to be able to do primary care, but I can tell you they are so desperate that right now I haven't done primary care in a very long time. I've told them that I prefer not to, and they have scheduled me only emergency medicine shifts. So I did not need to do primary care, but it would be great if you can do that. And if you can't, that's okay. There's so many colleagues that can help you over the phone. When I first went up north, I went with a colleague who's a primary care physician, and oh my gosh, after every clinic I had so many questions, and I was just like, first of all, what's diabetes and how do I manage it? Is it DKA or like what do I can I start them on a DKA protocol? No, Nour, they just have regular diabetes. So like you have to kind of change your framework, but there's colleagues there to support you and help you. Like if you're not comfortable with primary care, they won't put you in primary care. The need is there in every aspect, not just primary care.
Absolutely. And before you went up and started some of these positions, did you receive any sort of special orientation?
Very good question. I did not. I started a few years ago, but right now I believe that you do need cultural sensitivity training, which is just basically like an online thing that you have to do. When you do go up north for the first time, I know I made it sound like you're all by yourself and everything. there's still like a chief of the department who is in charge of you, right? And they won't let you do your first shift all by yourself if you're not comfortable. So it's not really, you're not really like thrown into the wolves like I described it. You are in the middle of the night if you pick up, if your first shift is a night shift for sure, but you know they wouldn't do that to you. They understand, and a lot of people go there when they first graduate. So which is what I did. You know, I don't recommend it. I recommend a few years in, but even if you do it, just do it and make sure that you have the resources, or that there's other doctors there at the same time. Not that you're not going in a time when they're really really desperate. There is a time in Fort Smith where there's one doctor for an entire 2 weeks. So that doctor has to cover the emergency department and primary care, which is absolutely insane. But you just, you know, you just tell them that you don't want to do it when they're completely desperate.
Gotcha. All right. Thank you for that. And I think that's all the questions that are in the chat right now. But thank you for answering all of those. And I imagine if there's any further questions, you can probably reach out to Dr. Khatib with her email in the chat, as well as her Twitter handle. And I just wanted to say thank you again for giving this talk. It was really amazing.
My pleasure. My pleasure. Of course. Thanks so much for the feedback, guys. I'm looking at the chat. Thanks so much. I'm glad you enjoyed it.
Absolutely. All right. And for everybody, we'll see you in a couple more weeks for our next session, which I think is the showcase, if I remember correctly. So we'll see everybody there.
Have a good night.